Hello and welcome back. I will talk today about RSV prophylaxis. Because we are approaching the season of RSV, these guidelines can help you know the indications and the precautions that need to be taken in order to provide proper RSV prophylaxis in proper time. So during this lecture, I will talk about bronchiolitis in brief. I will mention what's RSV, the high-risk group, and what's RSV prophylaxis, then a protocol proposed by the American Academy of Pediatrics. So bronchiolitis is a constellation of clinical symptoms and signs, including a viral respiratory prodrome, followed by increased lower respiratory effort and wheezing in infants. Bronchiolitis affects around 1% to 3% of all healthy children and more than 10% in the high-risk groups, which we will mention later. RSV is the predominant organism responsible for around 70% of bronchiolitis cases worldwide. The mortality of bronchiolitis is high in the high-risk groups, reaching up to 47% in chronic lung disease and around 49.7% in congenital heart disease infants. So RSV, or respiratory syncytial virus, is a highly contagious respiratory virus that infects the lungs and breathing passages. RSV is a highly transmissible virus, and the only known reservoir of this virus is humans. However, RSV has been shown to survive on fomites such as tabletops for up to 6 hours. And this emphasizes the role of hand hygiene in preventing the spread of respiratory syncytial virus. So talking about the RSV in details, RSV is an RNA virus, encodes 10 proteins, including 2 envelope proteins, the F and G. As you can see, the F, or fusion protein, and the attachment protein, G, these are the 2 important proteins that we need to remember. So the G protein here mediates the attachment of the virus to the host cells. So G protein mediates attachment, and the F protein involved in the cell penetration and promotes cell-to-cell transmission through the formation of syncytia. So G protein for attachment and F protein for penetration. The high-risk groups to develop bronchiolitis and to develop severe bronchiolitis include preterm babies, babies with chronic lung disease, babies with congenital heart disease, immune-compromised babies, babies with Down syndrome, babies with cystic fibrosis, and anatomic pulmonary abnormality. Now, RSV prophylaxis. What's RSV prophylaxis? It's a humanized monoclonal antibody produced by recombinant DNA technology that is composite of human, 95% human, and 5% murine antibody sequence. It binds to the F portion, remember the F protein, of the RSV, which is the protein used for penetrating the cells. So the RSV binds to the F protein and effectively neutralizing the virus and preventing its entry into the cell. Palivizumab, which is the RSV prophylaxis or the antibody, was licensed in June 1998 by the US Food and Drug Administration for the reduction of severe lower respiratory tract infections caused by the RSV in certain risk groups. What about efficacy and safety of this prophylaxis? It was found through systematic reviews that palivizumab can reduce the RSV-related hospitalization, the length of hospital stays, the progression to ICU admission, the duration of oxygen support, The occurrence of wheezing episodes during the first year of age, the mortality in high-risk populations. How safe? Yes, adverse effects were erythema at the site of injection, fever, or diarrhea. Now, how to administer RSV? Palivizumab should be administered up to a maximum of 5 monthly doses. It's given as 15 mg per kg per dose, administered intramuscularly once every 28 days. It's given during the RSV season to infants who qualify for prophylaxis. Usually the season extends from October or November to March. The injection palivizumab should be stored in a refrigerator at 2 degrees Celsius to 8 degrees Celsius. Palivizumab does not interfere with routine childhood immunization, so you can immunize children regardless of the time you give palivizumab. The recommendations. Now, this is the most important part of the lecture that you need to memorize, but if you cannot, please keep a reference that that facilitates the referral of these kids for RSV prophylaxis. So any baby who is delivered before 29 weeks gestation and he approaches the or he is in the season of the RSV bronchiolitis, when he is less than 1 year old, is candidate for the RSV prophylaxis. If after 29 weeks and healthy, there is no routine recommendation. But if the baby is less than 32 weeks and is having chronic lung disease, he fulfills the criteria during the first year of life. For babies with congenital heart disease, and it should be hemodynamically significant congenital heart disease, they need to be given the prophylaxis in the first year of life. Pulmonary abnormalities or neuromuscular disease that impairs the ability to clear secretion only in the first year of life, and if the baby or the child is profoundly immune compromised, he will need the prophylaxis during the 24 months of life. You can see that babies with Down syndrome are not included here, because if Down syndrome by itself is not a risk factor, but because babies with Down syndrome, they are liable to have congenital heart disease, they are liable to have chronic lung disease, and they are liable to be delivered prematurely. So they are at higher risk to be liable to have bronchiolitis. Other important recommendations to keep in mind: ASD secundum, VSD, PS, uncomplicated aortic stenosis, mild coarctation of the aorta, and PDA are considered as hemodynamically insignificant and does not indicate a need to give RSV prophylaxis. If the baby is delivered during the season, he may need less doses. So let's say that the baby is delivered on December, and the first dose will be in January. So he will receive in January, February, and March. This means 3 doses, and we need not to complete 5 doses for the prophylaxis. Babies with chronic lung disease, even if on treatment, it's not recommended to give them in the second year of life. So in the first year of life only, even if they are receiving treatment. If the baby or the child develops RSV during breakthrough RSV and need hospitalization during the season, we need to discontinue giving other injections. Babies with Down syndrome, as we said, there is insufficient data to recommend RSV prophylaxis. And last thing, palivizumab prophylaxis is not recommended for the prevention of healthcare-associated RSV disease. These are the references, and thanks for watching.